Welcome to the GMJ Podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy. This episode reviews the article titled, Evaluating the 2019 to 2030 WHO Global Action Plan on Refugee and Migrant Health, a baseline analysis of 93 member states.
Thank you. It is really great to be here to unpack this.
Yeah, and to jump right into this deep dive, I want you, the listener, to just imagine something for a second. Try to picture a population roughly the size of a massive global metropolis.
A huge demographic.
Exactly. But this entire metropolis is completely invisible to modern medicine. And it's not because they're, actively hiding. It's because our medical data systems are fundamentally not programmed to see them at all.
Yeah, it's a structural blindness. And that is exactly the central thesis of the GMJ article we are looking at today. We are unpacking a landmark document from April to 2026, which is the WHO's first really comprehensive global baseline report on refugee and migrant health.
Right. And they're evaluating progress on that global action plan that runs from 2019 to 2030 using hard data from 93 different member states.
Exactly. The core research question here is basically how well are these 93 nations actually integrating highly transient, vulnerable populations into their national health systems?
Which is such a tough conceptual problem. I mean, think about the last time you had to fill out a medical intake form at a new doctor's office.
Oh, the paperwork is always endless.
Right. You write down your permanent address, your insurance code, your tax ID, maybe an emergency contact. But imagine trying to navigate that exact same form when your address changes weekly.
Or, your emergency contact is literally in a different hemisphere.
Exactly. And your tax status just does not map to the local grid at all. So our mission today is to look at how these health systems are trying to integrate a population defined by motion and where that integration is just actively breaking down.
Well, to establish that baseline, the authors of the GMJ piece suggest we really need to look at the structural commitments first. And there is some good news here.
Oh, really? Okay, what did they find?
The report shows a pretty significant policy shift among these member states toward including refugees and migrants in universal health coverage or UHC frameworks.
Okay, so on paper at least, the legal scaffolding is going up.
Precisely. We're seeing this widespread philosophical acknowledgement at the policy level that health access shouldn't just be tethered to your origin or your citizenship status.
Right, but I want to look a little closer at the underlying mechanics of that policy shift.
Yes.
Because UHC, it is heavily reliant on predictable risk pools, isn't it?
Yes, absolutely. Whether it's a tax-funded model or an insurance-based model, the math requires stability.
Right, the whole system relies on a stable, measurable base of contributors to fund care without bankrupting the patients. So if a country integrates a transient population into its UHC model, aren't they introducing all these dynamic, unpredictable variables into a funding mechanism that was built for static residents?
That is exactly the friction point. And it's what the GMJ review highlights as the implementation gap.
The implementation gap.
Yeah. So a Ministry of Health can mandate inclusive care at the federal level, right? But if a local hospital's funding is strictly tied to the census of permanent taxpayers in its specific district.
Ah, I see where this is going. Treating a sudden influx of migrants drains those local resources.
Exactly. It drains the resources without replenishing the funding pool. So that inclusive, noble policy actually creates a massive unfunded mandate down at the clinical level.
Which means the hospital administrators are, they're basically structurally incentivized to introduce administrative friction.
Yes, unfortunately.
If the clinic can't afford the influx, they might start strictly enforcing documentation requirements that they know transient populations just don't have.
Right, effectively closing the door without ever technically violating the macro policy.
It's like having a VIP ticket to a concert. The inclusive policy, but you show up and the venue doors are just padlocked.
That is a great analogy. The 93 member states have largely adopted this macro policy of inclusion, but the micro policies, the daily administrative protocols, they remain highly exclusionary.
And I think that's why the WHO uses those 6 distinct priority areas to measure the gap, right? They aren't just looking at emergency room admission rates.
No, they're analyzing the entire ecosystem of health generation.
Right, because the framework is incredibly dense. It tracks short-term and long-term health, continuity of care, tackling social determinants, health monitoring, all of it.
Let's actually focus on the continuity of care piece, because the baseline report flags this as a massive structural failure. Healthcare for non-citizens is almost always episodic.
Episodic, meaning they only get treated when it's an absolute crisis.
Exactly. A migrant might receive an emergency intervention for, say, a severe asthma attack, but then they are denied the long-term continuous care like regular checkups or preventative inhalers.
Which would keep them out of the emergency room in the first place.
Precisely.
But wait, that feels completely economically backwards. I mean, emergency interventions are exponentially more expensive for the host nation than just giving someone an inhaler.
It is entirely counterproductive. But again, it goes back to those funding mechanics. Preventative care requires establishing a permanent medical record, scheduling follow-ups, assigning a primary care doctor.
Oh, and the administrative architecture just refuses to absorb them into that permanent registry.
Right. The system will absorb the one-time massive cost of an ER visit to save a life, but it won't absorb the individual.
Wow. And we see that same systemic friction when we look at the social determinants of health, too. Because medicine is really just the repair shop.
Oh, absolutely. If you look at occupational health, for example, a migrant working in agriculture might be exposed to severe chemical hazards.
But because of their visa status, they totally bypass standard labor protections.
Right. They are structurally incentivized to hide from the monitoring system.
Because if you seek treatment for pesticide exposure, you risk your job, or worse, you trigger a deportation inquiry. So you just endure the exposure.
Exactly. That inclusive UHC policy championed by the health ministry. It's completely neutralized by the labor and immigration realities on the ground.
That brings me to the core methodological consideration of this whole report, the data. The GMJ article flags limited data systems as the root cause for almost all of these implementation failures.
It really is the foundational crack in the system. It's an architectural flaw in how health data is gathered and processed globally.
Because national health databases are fundamentally built on static architecture, right?
Right. They index you via permanent identifiers, social security numbers, consistent addresses, long-term medical histories.
And migrants inherently lack those markers.
Exactly. They introduce dynamic variables that traditional health informatics infrastructure simply cannot compute.
It's basically a massive software incompatibility issue.
Yeah.
You've got this highly advanced operating system, the National Health Grid, trying to read a totally incompatible file format.
That's exactly what it is. The system isn't programmed to maliciously reject the migrant data, necessarily. It just literally lacks the fields to process things like fragmented medical histories from 3 different transit countries.
When the OS can't read the file, the data just gets dropped.
It gets dropped entirely. The individual becomes a statistical ghost. And the report emphasizes that if a population isn't tracked by the monitoring systems, they effectively do not exist for resource allocation.
You can't provision for a ghost. I mean, if the regional health authority is deciding where to build a prenatal clinic or how to distribute a finite supply of vaccines, the needs of the transient population just do not factor into the algorithm at all.
No, because the budgets are set using a map that is missing half the topography.
Right.
And trying to track this data is incredibly complex, which is why the 2026 baseline shows such profound deficits. Even when transient populations interact with border health checkpoints or NGOs, that data rarely integrates with the permanent registry.
Because the databases are totally siloed. The Border Patrol's screening software doesn't talk to the provincial hospital's intake software.
Exactly. And that lack of interoperability means chronic conditions go unmanaged. A patient gets diagnosed with hypertension at a transit camp, but by the time they settle in a host community, that history is lost in the digital void.
So the local clinic has to start the diagnostic process completely from scratch. What a waste of finite resources.
It delays critical care and drains the system, yeah.
Well, if the everyday data infrastructure is failing this badly, the system-level implications for sudden crises must be terrifying.
They are. The report highlights a staggering blind spot regarding emergency preparedness.
Right, because refugees and migrants are structurally excluded from those emergency plans, which is a dark irony, considering they are very often people actively fleeing emergencies in the first place.
Right. When a state drafts a response strategy for an earthquake or a novel infectious disease outbreak, they deploy resources based strictly on the population they can actually see in their databases.
So the evacuation routes, the mobile triage units, the emergency broadcast languages, they're all optimized only for the static, documented population.
While the invisible populations, the ones living in informal settlements that the data system dropped, they are left completely outside the response radius.
And that transforms a localized vulnerability into a massive national security issue, doesn't it? because pathogens do not check legal residency.
They map biological density, not visa status.
Yeah.
Exactly.
So by failing to integrate these populations into emergency vaccination plans, host nations are inadvertently cultivating reservoirs where an outbreak can just spread completely undetected.
Yes, the virus uses the invisible population as a biological bridge, and it eventually overwhelms the resources of the static population anyway. You cannot selectively protect a population from an airborne pathogen based on citizenship.
It's mathematically impossible. So having diagnosed all these massive institutional failures, what are the policy implications? How does the WHO propose these 93 nations actually fix this?
Well, closing this implementation gap requires stronger leadership, sustained financial investment, and what the report terms cross-sectoral collaboration.
Okay, cross-sectoral collaboration. Let's strip away the institutional jargon for a second. What does that physically require a government to do in the real world?
It requires acknowledging that health equity cannot be achieved solely through a doctor's visit. Treating a severe respiratory infection with antibiotics is entirely futile if the patient has to return to a damp, overcrowded informal shelter.
Right, because they're structurally locked out of the local housing market. The medical intervention is just treating the symptom of a much larger infrastructure failure.
Exactly. So, for true cross-sectoral collaboration, the Ministry of Health has to interface directly with the Housing Authority, the Education Board, and most critically, immigration enforcement.
Immigration. But wouldn't that just scare patients away even more?
Well, that's why this interface requires the construction of strict administrative firewalls.
Firewalls. Okay, explain how that works.
We talked about the patient who avoids the clinic due to visa fears, right? True collaboration means establishing legal firewalls between healthcare provision and immigration enforcement. A clinic must be able to share demographic data with the housing authority to improve shelter conditions without that data automatically triggering a deportation proceeding.
So you have to fundamentally decouple health access from citizenship status at the administrative level. The actual software has to be rewritten so that a passport isn't a mandatory hard-coded field just to generate a patient record.
Precisely. And furthermore, it requires coordinated financial investment. If the health ministry mandates inclusive care, the finance ministry has to adjust the funding algorithms.
They need contingency budgets that respond to real-time population shifts instead of just looking at last year's static census.
Right, funding models that actually travel with the patient.
Which all circles back to the core finding of this 2026 baseline report. The UHC policies represent a really vital shift in legal philosophy. We are acknowledging that health is a fundamental right, not a privilege of geography.
The scaffolding is up. The 93 member states analyzed here have demonstrated the political will to draft inclusive frameworks. But the next phase of the WHO Global Action Plan has to pivot from policy generation to deep architectural reform.
Right, rewriting the software of public administration, building those critical firewalls, integrating informal settlements into the emergency maps.
Because the resilience of the global health network depends entirely on eliminating these blind spots. Human migration is a continuous feature of our global landscape. Trying to manage a dynamic phenomenon with rigid, static infrastructure is just socially unsustainable.
And an inclusive system is fundamentally a more robust system for everyone, right? Hardening the weakest links makes the whole chain stronger against systemic shocks. We all share the same biological vulnerabilities.
Exactly. And I think the timeline here presents the most significant pressure point in the whole analysis. The WHO Global Action Plan operates on a defined window from 2019 to 2030.
And we are dissecting this baseline in April of 2026. So the starting line has really just been drawn.
Yes, and it leaves us with roughly 4 years to rewrite the underlying architecture of global public health administration.
Which is a lingering, honestly staggering thought to leave you with today. If it took 7 years just to map the failures and establish the baseline, what unprecedented mechanisms of international cooperation are going to be required to rebuild the system before the 2030 deadline?
The scale of the required shift is monumental. It really demands a complete reimagining of how states define responsibility.
It certainly does. Thank you for listening to the GMJ podcast. For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description. We look forward to continuing these scholarly discussions in future episodes.